Welcome everyone to today's webinar, Where Have All the Infectious Disease Specialists Gone? Filling the Gap with TeleID. On behalf of Becker's Healthcare, thank you for joining us. Before we begin, I'm going to walk through a few housekeeping instructions. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You could submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We're here to help. With that, I am pleased to pass the floor over to David Zinn, President and CEO at Infectious Disease Connect. All right, I will hand the floor over to Dave.
Thank you, Beckers, and thank you everyone for joining us for today's webinar. The webinar is entitled, Where Have All the Infectious Disease Specialists Gone? And Filling the Gap with TeleID. I'm Dave Zinn, and I'm the President and CEO of Infectious Disease Connect. ID Connect is a specialty telehealth company that directly works with hospitals, hospital systems, and other organizations to bring infectious disease services to their physicians and their patients. ID Connect provides full-time, part-time, and backup ID services using telehealth to approximately 100 different hospitals today. While the pandemic highlighted telehealth capabilities and the importance of infectious disease resources, it also further stressed ID resources as the industry is experiencing severe shortage in ID specialists. Today, many hospitals are struggling to or simply can't find ID specialists, APPs, or pharmacists to fill their open positions. And the onslaught of infectious disease keeps coming. In the last several months, surges in RSV, increases in Candida auris, and the identification of new strains of COVID and the detection of Asian flu in humans is only a few examples of recent ID headlines. Therefore, we want to spend the next 40 to 45 minutes digging into our current ID crisis and discussing how TeleID is a viable solution for hospitals and health systems of any size. To help us explore the topic, I would like to introduce our esteemed speakers. First is Dr. John Mellers. John has been the Chief of Infectious Disease at the University of Pittsburgh and UPMC since 1999. He has over 30 years of experience in laboratory science, clinical investigation, and pharmaceutical development. In 2013, John developed UPMC's TeleID program, and due to its success, in 2019, ID Connect spun out of UPMC and became its own individual services company. Next, Dr. Rima Abdelmasih. Rima is a co-founder of ID Connect, and she currently serves as the company's chief medical officer. In addition to her CMO duties, Rima is the UPMC Director of TeleID Services, the Health Systems ID Fellowship Training Program Director, and a member of the Infectious Disease Society of America's work group on telehealth. Next will be Dr. Karen Bash. Dr. Bash serves as the Chief Medical Officer at WakeMed North Hospital. Dr. Bash has been a member of the WakeMed team since 1992, serving in a wide variety of leadership, quality, and teaching roles at WakeMed and the University of North Carolina School of Medicine. Finally, Nancy Zimmerman will be moderating today's Q&A session. Nancy is Vice President of Clinical Operations of ID Connect. Nancy leads the team that delivers clinical oversight to all of our ID services, implementation efforts, and ensures satisfaction of all our clients' clinical and operational needs. Nancy has her Bachelor of Science in Nursing from Johns Hopkins University and a Bachelor of Arts in Psychology and Education from Bucknell University. John, Rima, and Karen will specifically address how the world of ID is evolving and explore the decreasing supply of ID specialists. They will then discuss how TeleID can help close the supply-demand gap. Rima will share some recent data that compares TeleID to in-person ID consultations. Next, Dr. Bash will address how TeleID works in the real world by sharing insights gained by WakeMed's partnership with ID Connect. And finally, we will close by having our panelist of experts address your questions. So let's get started, and I will turn the webinar over to Dr. John Mellers. John?
Hello there. My name is John Mellers, and I'd like to tell you about an important paradox that's happening in medicine, and that is the difference between demand for infectious disease and supply of infectious disease expertise. So there's clearly growing demand for ID expertise. There's an aging population and more therapies that are immunosuppressive and put people at risk for fatal infections. There's the growing threat of antimicrobial resistant organisms, which has been designated as a high priority by the WHO and the CDC. There's continued risk of outbreaks. We've all lived through a really difficult time with COVID-19. Avian influenza is lurking on the horizon. We're in the middle of a Candida auris, which is a multi-drug resistant fungus or yeast. And there are many other drug-resistant pathogens that are potentially spreading throughout our health systems. And there are expanding regulatory mandates for antimicrobial stewardship and infection prevention and control. And just to remind you of some of the outbreaks that have occurred in the 21st century: SARS-1, dengue, cholera, swine flu, measles, MERS, which is the second human coronavirus that has spread in the Middle East, Ebola, Zika, another outbreak of Ebola, and COVID-19, which caused a really complicated and lethal pandemic. And there are important patient and hospital costs of poorly managed infections in the billions of cost for hospital-acquired infections. Many millions of individuals are misdiagnosed or underdiagnosed, and only a small fraction of hospitals meet CDC recommendations for antimicrobial stewardship. And many antimicrobials are prescribed unnecessarily for self-limited viral infections. This breeds resistance, and 1 in 25 hospitalized patients acquires a hospital-acquired infection. So there's documented value of ID specialists, shortening the length of stay, promoting discharge to home rather than intermediate care, lower readmission, prevention or minimizing nosocomial outbreaks, decreasing rates of hospital-acquired infections, better use of antimicrobials with less toxicity and cost, and lower resistance. And this is documented in various studies and recently reviewed by McQuillan et al. In Journal of Infectious Disease and Smith et al. In CID, for those who are interested. There's a very striking gap in ID expertise coverage in the United States. Rochelle Walensky, the head of the CDC, published this really important article in the Annals of Internal Medicine in 2020, showing that 80% of counties containing over 200 million US citizens are without access to an ID physician. And I'd like to say that things are getting better, but they are not. They're actually getting worse. We have an aging ID workforce, predominantly male. 80% of physicians, ID physicians, are between the ages of 65 and 69, as shown here in this graphic. And sadly, fewer individuals are going into infectious disease, and this is reflected in both adult and pediatric infectious disease training programs. This past year, 44% of training programs went unfilled. They had slots for training that were not filled, and over 50% of pediatric ID slots were unfilled. So why is it difficult to be an ID doctor, and why are people not going into it? Well, there are few jobs in desired locations or that meet visa requirements. There's inadequate salary and compensation relative to similarly educated peer groups. There's often an undesirable mix of clinical activities, inpatient, outpatient, and general medicine practice. There can be lack of senior mentorship and support grouping at remote sites, and there's a high workload and risk of burnout. ID physicians report the lowest compensation and lowest happiness levels. They're ranked 17th in terms of 20 specialties with the lowest compensation. And they score as the least happy, with 47% reporting high levels of unhappiness. There are also women who are leaving the physician workforce, and this is another strain on supply. Women spend more time with patients and on documentation than their male counterparts. Women physicians are more likely than males to be responsible for childcare, schooling, and household tasks, and so they have less time to decompress when they finally get home. They view very differently how their workplace handles diversity, equity, inclusion compared with the male counterparts. There's a clear and ongoing gender gap in terms of pay, and there are higher burnout rates, lower professional fulfillment, and higher rates of depression among women than male counterparts. So will the US have enough ID physicians moving forward? The answer is no. Since the pandemic, 1 in 5 physicians intends to leave practice. The aging physician workforce I mentioned earlier. Younger physicians in practice want better lifestyle to be a priority. And I mentioned many women physicians are leaving the workforce and need to work fewer hours. And male physician work hours have also declined over the last 3 decades. And we have a dwindling supply of new ID fellows in training. And the AAMC projects a shortfall of around 100,000 physicians by the end of the next decade. So there's a troubling future for access to ID care. So adding it all together, there's a rising demand for expertise, reduced availability of ID specialists, and there's a critical need for new models of care. And this is why Dr. Abdelmasih and I founded ID Connect, is to provide expertise where it isn't. And telemedicine has been endorsed by the Infectious Disease Society of America and in this seminal paper that was issued. So why do ID physicians choose ID Connect? And we were very surprised and happy that physicians out of training and those in practice are choosing to work for ID Connect. And there's several reasons for this. Some we anticipated, some we didn't. ID Connect achieves the mission of providing top quality ID care. We offer a unique, highly sought after remote academic position that attracts physicians from top tier institutions. They have an academic affiliation with one of the largest ID divisions in the US. They receive faculty mentorship, career development, and promotion support. They have peer support and collaborations with world-class specialists at UPMC in the subspecialties and general ID. And the subspecialties include antimicrobial resistance, oncology-related infections, orthopedic infections, pediatrics, transplant infections, HIV, etc. And they can participate in resident and fellow education. There are novel opportunities also for research, quality improvement projects, and scholarly activities. And importantly, they have the advantage of being able to work from home and care for family members, including parents and children and their other loved ones. And so we think that we've provided a incentive for physicians to go into infectious disease, a highly desirable position, and the net outcome of that is that we provide expertise where it's not available in many of the counties that are noted to be absent ID expertise. And with that, I'll stop and turn it over to Dr. Abdelmasih to tell us more about the services provided by ID Connect. Thank you very much for your attention.
Thank you, Dr. Mellors. And now I'm going to talk to you about how tele-ID compares to in-person ID. And for that, I'm going to first go over our usual tele-ID model of care. So for that, we do provide 3 types of visits. The first one is the live audio-video tele-ID visit. That includes obviously reviewing the records, placing a detailed documentation in the chart, but also includes taking a full history, providing a comprehensive exam, along with the telepresenter on site with patients. And that type of visit can be used as initial or follow-up visit. The second type is the e-consult. That is the asynchronous visit, where there is no necessarily need to take additional history from the patient or perform an exam. So we do review the records, we do still place documentations of the chart, we can communicate with the team. And that type of visit is also can be done as initial or follow-up visits. And then lastly, the telephonic physician-to-physician consult, which is usually for rapid or simple questions, and then for after-hour consults as well. In our ID physician determines for consults based on patient complexity, which type of visit to use, whether the live visit or the e-consults visit. And so I'm going to go over a few studies that our group has published. And first, I want to mention that this work has been done by our tele-ID research work group. It's truly a testament of the great work and high quality care they provide to our patients. So I'm truly proud to be part of that team and to present the data that this group has been able to show. So the first study is led by Dr. Nupur Gupta. This is actually the first longitudinal analysis of a long-standing tele-ID service. It's a 6-year analysis of our service at a community hospital between January 2014 to June 2019. That hospital is a 126-bed rural hospital in Pennsylvania that had no access to ID consultations before. The type of visit used over those years was the live audio-video consult visits with the telephonic consults availability 24/7. The outcomes of consulted patients in that studies are listed here, and they're pretty similar to what has been published previously in the literature. What's striking to see first is that the number of encounters increased over the years. So there was increased adoption of the service, and also what's very important to note is that the Alex Howard comorbidity index increased from 2.9 to 6.6 by 2019, which means we were able to allow the retention and to care for higher complexity patients, which otherwise would have been transferred to other institutions. So this is a nice study, again, because also it can show that tele-ID can be a long-term solution for ID need coverage and consultation services. Now, one could say, okay, fine, of course, it's going to be better than no presence of ID care, but how does it compare to in-person ID care? So again, our group wanted to report some of our experience in that area. The first study by Dr. Nanjapa, here I'm showing, is a study that compares a comprehensive tele-ID model to a periodic in-person ID care coverage at a community hospital. This is a 164-bed community hospital. The two groups that we studied, the first one was from January to November 2019. And we had the 100 consecutive patients seen by an in-person ID physician that was visiting that hospital every third day and available for telephonic questions on the other days. And we compared that to 100 consecutive patients that we saw once we started our tele-ID service, and that was between May and August 2020. The tele-ID service model provided here included the live audio-video visits, the e-consults, and the telephonic consults. And so looking at the patient's demographic, they were pretty similar between both groups. We did see some more elderly patients in our group. What was important to note here is that the morbidity index, again, this is the Charlson comorbidity index score, that was higher in the tele-ID group. And despite the fact that it's higher, which means, again, we're retaining those complex patients, we were able to decrease length of stay, notably, and also we were able to discharge less patients on IV antibiotics and more on PO antibiotics. So this was also important to know, comparing intermittent in-person ID coverage to a telemedicine service. Now, how about a direct comparison between an in-person traditional ID service and a telemedicine infectious disease service? And this is a study by Dr. Nupur Gupta that was published last year in OFID. The study sites were 3 hospitals that belong to one same system, a total of 432 beds. There was one ID physician covering those 3 hospitals, and it would take about 1 hour, 40 minutes to travel that distance between those 3 sites to be able to see patients in one single day. And so we elected to compare patients between the first 6 months from our tele-ID service to the prior 6 months when that in-person ID physician was still available. So the time period, the first one for the in-person ID physician was between January and June 2018, and for tele-ID, right after that, between July and December 2018. The service model, again, our live audio-video consult, e-consults, and telephonic consults. So the primary outcomes of those patients that we were consulted on, we are dividing them by hospitals because they share, while they were in the same system, they had different EMRs. So there's hospital 1, and then the 2 other hospitals were grouped together, as these 2 did in fact have a shared EMR. We did notice that within the tele-ID group, we were able to see more patients. There were more overall total encounters. Again, this is probably due to the ability to cut down on travel time, where we were able to be more efficient. Interestingly, we were able to have the same length of stay, ID readmission rate, and transfer rate compared to in-person, which is great news. Again, here, the Charlson comorbidity index in the in-person group was noted to be around 5.9 on average compared to 6.4 in the tele-ID group. However, we were also able to decrease the overall antimicrobial usage within the tele-ID group by 4.7%. Another interesting data that we saw in this paper is that tele-ID is truly able to make a wide range of diagnoses, as you see on this slide here. So we have been able, and with the right model, with the right expertise, to make different types of diagnoses, even specific ones, as you see on the slide, noted in blue. Now, this is a bit of a gutsy study, but I'm really thrilled we were able to get that study done. It's also led by Dr. Nupur Gupta. And in this study, we wanted to see, is tele-ID service as a model, could it work in our academic institution? Now, this is an important question because we are seeing shortage of ID physicians even in our academic centers. And so could that be a potential future model? And so I have some encouraging data here. This is a longitudinal matched case control study. The study sites were the 3 tertiary academic medical centers in Pittsburgh, which are together over 1,300 beds. Now, we had the opportunity during COVID to shift our in-person traditional care to telemedicine, where we deployed telemedicine capabilities to all our floors at these 3 sites. And this is the data we saw from cases we saw during the time period between March 1st, 2020 to May 31st, 2020. This was around the lockdown, if you'll recall. And during that period, those are the cases we saw either by live audio video consults, e-consults, and then of course, including the telephonic coverage. And then we compared those cases to our controls, and we elected to choose the same time period the year before. We didn't have COVID during that year, compared to in-person consults performed between, again, March 1st, 2019 to November 30, 2019. So both groups were evaluated by the same general ID group of physicians and the same transplant ID teams. Of course, we excluded the COVID-19 diagnosis. Those are the characteristics of the tele-ID cases we saw during that period. A total of 125 cases were in the general ID group and 81 in the transplant ID group. And I want to note this is also the first paper observing experience of tele-ID within transplant ID. And so, as you see here, there are different types of transplants that were included, including also stem cell transplants and CAR T cells patients. And so, interestingly, when we looked at the outcomes of the matched in-person control to tele-ID cases, we were very happy to see that we had pretty much similar outcomes. I want to note that 34% of the matched cases were transplant patients. Additionally, we noted that the tele-ID cases demonstrated significantly lower 30-day readmission rate, but also a shorter ICU length of stay. Now, keep in mind, this was during COVID, but this is extremely encouraging data that tele-ID, when done right, it can be even done in our academic institutions and for our most complex cases. Now, it's important to always look at our patient satisfaction, acceptance, but also our customer satisfaction. So we do perform patient surveys at our sites, and we are happy to report also that we have very high satisfaction rate by our patients, as you see noted here. All of them would want to be seen by telemedicine again, and I've included a couple quotes from our patients. We also were very fortunate to have a class spotlight report highlighted here too, with excellent ratings from our customers. I did want to share a couple notes from colleagues and partners we work with at our ID Connect site, from a surgeon mentioning that our service is the gold standard in telemedicine and patient care, and from a chief hospitalist co-lead mentioning how our ID physicians help reducing their burnout, and it's a relief whenever we're following patients with them, as they know there'll be comprehensive notes and that our physicians are always available when they need them. And with that, I would like to close with our summary that ID Connect provides a successful model of remote access to care. It can shorten length of stay, decrease patient transfers, optimize antimicrobial utilization, manage high complex patients, and enhance patient satisfaction. With that, I'm going to turn it over to Dr. Bash, who will be giving you an overview of our tele-ID service on the front line at WakeMed. Thank you.
Okay, thank you, Rima. I appreciate the opportunity to share a bit more about why WakeMed North chose to look for a tele-ID partner and why we ultimately began working with ID Connect. So first of all, I'd like to provide you with a better picture of WakeMed North. We're the third hospital in the WakeMed Health and Hospital System, and we're located in northern Wake County in Raleigh, North Carolina. We opened the hospital in May of 2015 as a women's hospital, but transitioned to a full-service community hospital in May of 2016, serving the entire community. Our patients are primarily commercially insured, and North Raleigh is a rapidly growing market. As you can see, we have 77 acute care beds. We have over 1,600 on our medical staff, including physicians and APPs, just under 700 employees. Our emergency services is quite busy. We saw over 48,000 patients last year, and we anticipate having closer to 50,000 visits this year. As I said, we started as a women's pavilion and birthplace as a women's hospital, and so our births have also steadily increased. We delivered more than 1,600 babies this year, and we're on track for more than 1,800 for next year. We have a special care nursery, and that's staffed 24/7 by our neonatal nurse practitioners, and they are backed up by our neonatologists who also cover our level 4 nursery at the main Raleigh campus. We have an intermediate care unit that is staffed by our hospitalist service, but it's backed up by our EICU. And this summer, we anticipate starting a build of a 9-bed ICU unit. Surgical services is also quite busy. We did just under 7,000 procedures between surgeries and endoscopies. And then we also have a physician's office pavilion that is here on site that helps to support our procedural lists. So prior to the pandemic, we actually realized the value of telemedicine, and we expanded our telemedicine coverage during the pandemic. WakeMed North uses telehealth services for behavioral health. We have a hybrid tele program for endocrinology. We have teleneurology. We have an inpatient telepain service. We also do our palliative care consults via telemedicine, and we have a telestroke program as well as our infectious disease program. Just like everyone else around the country, we're challenged with staffing shortages, and we need to utilize our resources judiciously. So in looking for a partner for tele-ID, one of the concerns was that our ID support from our main campus just wasn't available on site. Our admitted patients were often transported to our main hospital campus for the ID consults. Funding a full-time ID physician, even when we could find one, wasn't practical, and our volume and acuity of our patients has increased steadily throughout the years. We needed a more comprehensive support system for our hospitalists, for the proceduralists, and for the community in general. So, like I said, not only funding for an ID person was an issue, but it's also very challenging to find someone in the current market. With our proximity here in Raleigh to the Research Triangle Park, physicians and APPs as well as nurses have the opportunity to leave the bedside and work in industry without having to move from the area. So prior to partnering with ID Connect, we transported our patients to the main campus, which is our tertiary care center. And as you can imagine, this was a dissatisfier for our patients as well as the clinicians and nursing staff. It resulted in inefficient care, delayed evaluations, and we were tying up our mobile transport teams. So it simply was not a good use of our resources. It's been really easy to work with our ID Connect partners. They provide all the necessary information to our credentialing specialists for their clinicians admitting and consultative services. At our institution, we have a telepresenter who schedules and coordinates our in-person teleconsults, which are scheduled between 8 a.m. and 12 p.m. Monday through Friday. We have e-consults that are also available 8 a.m. to 5 p.m. Monday through Friday, and our telephone consults can occur 24/7, including weekends, holidays, and they're coordinated between the clinicians. ID Connect clinicians leave very detailed notes on our EMR after any type of interaction with our patients or staff. We have a telemedicine template that's utilized by all of our telemedicine services, and that assures that our billing department has all the information necessary to submit claims. Our staff, clinicians, and patients are very comfortable with the process. We have an allied health professional, which is currently a certified nursing assistant. In the past, we've used a radiology tech who functions as our telepresenter. We provide training in our sim lab to support the physical exams. And then if our telepresenter is unavailable for any reason, the patient's primary nurse or one of our nurse educators acts as the presenter. However, we found that asking the primary nurse to function as the telepresenter was not as efficient. There's more difficulty in scheduling the time with our consultant, and there are more interruptions during the visit. Nursing does assist the telepresenter with certain parts of the examination when needed, like a wound assessment, interpretation of heart or lung sounds, scoring edema, strength assessments, and things like that. So in looking at the value of WakeMed and the ID Connect partnership, our partnership with ID Connect allowed us to have access to the academic level ID expertise. ID Connect service also is customized to meet our needs, and the ID physicians provide a comprehensive approach to the patient care. The tele-ID service allowed us to retain patients in our hospital and not have to transport them for their ID consults. Thank you very much for allowing me this time today to speak about WakeMed North and our partnership with ID Connect. I'd like to now turn the presentation over to Nancy Zimmerman.
Thank you, Dr. Bash. As Dave mentioned at the start of the presentation, I'm Nancy Zimmerman. I'm the Vice President of Clinical Operations here at ID Connect. We've been monitoring the audience's questions, and I wanted to leave time to address some of these comments and questions. So let's start with Dr. Mellers. Dr. Mellers, what is the single most important thing we could do in the inpatient hospital setting to help prevent the spread and/or mutation of respiratory viruses?
Thanks for the question, Nancy, and to whoever in the audience asked it. There's not one single thing. It takes a comprehensive approach, including masking, cough and hand hygiene, early diagnosis, isolation of respiratory virus positive individuals, and treatment, if available, for the specific virus, for example, SARS-CoV-2 or influenza A. So it requires a comprehensive infection control and prevention approach.
Great, thank you. Dr. Abdelmasih, what has been the biggest change in the delivery of tele-ID services that you've seen since you started running the program at UPMC in 2016?
Thanks, Nancy. That's actually a very important question. We have seen some very interesting changes in the delivery of tele-ID specifically. What we have been noticing, especially in the last couple of years, is the shortage of ID physicians in major, even metropolitan area. We're seeing that even in academic institutions. Like Dr. Bash mentioned, even if you're in Raleigh or in other larger cities, it's been striking that institutions haven't been able to find ID physicians when we thought it's going to be more of a community hospital, more of a rural area. The other change we're also noticing is the acceptance of tele-ID as a career, and especially for ID physician, it's been really interesting to see the shift from the traditional models of providing ID care to the tele-ID model, where there's more, obviously, work-life balance.
Interesting, thank you. Sort of along those lines, Dr. Mellers, what could be done to encourage more physicians and advanced practice practitioners to specialize in ID?
Well, there are several factors. I think one of the biggest factors is compensation that is equivalent to their peers with similar level of training. I think this is the biggest barrier right now. Hospitalists right out of medical residency can earn in excess of what an ID physician can earn. And then a better work-life balance, because there's a shortage of ID physicians. They're drawn on more and more, and they're not compensated for many really important cognitive functions that are related to antimicrobial stewardship and infection prevention and control, in addition to their clinical care responsibilities. So more appropriate compensation, better balance, and compensation for non-direct patient care activities.
Great, thank you. Dr. Bash, this next question is for you. What has been the most unexpected benefit of using tele-ID at WakeMed North?
Thank you, Nancy. Yes, that's an interesting question. Having the patients stay here at the hospital has certainly been a benefit, and not being transferred for their ID consults. But I think that one thing that we have seen is how great the acceptance has been. Our clinicians and our nursing staff have realized that we can start treatment programs much quicker for these folks, and that helps us transition them out of the hospital and either back to their home quicker or back to the facility that they may have been transferred from originally. And so it's been a great benefit.
Excellent. Thank you. Dr. Bash, can you comment on the change management culture at your institution and if that played a part in the adoption of tele-ID?
Well, I think when we initiated telemedicine in general, we had some cultural barriers to overcome. But since we've had the EICU for a number of years, we also had telestroke and teleneurology prior to initiating tele-ID. I think that we had overcome some of those barriers as far as our clinicians are concerned. When we did begin working with tele-ID, with the ID Connect folks, there was concern from our nursing staff about additional work for them in the ID consults. And that is why we started the telepresenter program. That has really helped with our nursing staff. And now they've really come on board and they're very pleased with our processes.
Great, thank you. Dr. Abdelmasih, many hospitals have ID physicians, but not enough to cover, their full current needs, which certainly puts more pressure on the ID team. Can your service be utilized to help offload the on-site ID physicians?
Absolutely, and this is a very important question, and thank you for that question. So as Dr. Bash has mentioned, and Dr. Mellers also has covered in his section, there is a very concerning shortage of ID physicians, and any ID physician today in the workforce, we want to do everything possible to keep them in that workforce and make sure they're not burned out. And that's what we're seeing, that they are overworked, they're burned out in different institutions. So yes, we have been able to come up with different types of models that we can customize based on what that institution specifically needs, what that ID physician group specifically requires, to be able to provide a supplemental service to help them and offloading their workload, which has been working very well, and it has been helping the institutions because sometimes they need 30% help, they need 50% help, and it's difficult to be able to recruit just that amount, for example.
Yeah, absolutely. Okay, Dr. Mellers, our administration wants to save on not hiring ID experts and expect their non-ID clinicians to take care of complex ID cases. How can we convince them that ID physicians are needed?
I can understand administration's needs to cut costs, but let me just tell you a personal experience. When I went into infectious disease more than 3 decades ago, the common sense was that the field had little opportunity for growth. We had vaccines, we had penicillins, we had 4 or 5 other classes of antimicrobials, and even the leaders of infectious disease thought the future was stagnant for the specialty, and anything couldn't be farther from the truth there. Infectious disease has become too broad and too complex to be diagnosed, treated, and managed as effectively by non-specialists as specialists. The number of antimicrobials and their resistance profiles alone are enormous and changing all the time. We now have specialists managing subsets of infectious disease, transplant, endovascular, bone and joint, surgical, etc. And I'll admit, I can't even keep up with the literature and the state of the art. So how would we expect a non-ID specialist to be able to do that?
Yeah, excellent points. Thank you very much. And I'm sorry, we're simply out of time today. ID Connect promises to directly follow up with anyone whose questions we couldn't answer just now. We appreciate everyone who joined us for today's webinar and know that copies of our slides will be sent to all attendees over the next few days. And finally, ID Connect also wants to extend a huge thank you to Dr. John Mellers, Dr. Rima Abdelmasih, and Dr. Karen Bash for sharing their insights about the evolving state of infectious disease care and the role that tele-ID can play. Thank you so much and have a great rest of your day.